But what about when we're first starting nutrition support? I've been asked to talk about the question, how and when do I start enteral and parenteral nutrition? But I'm actually going to turn it around because I'm going to start with the easier question to answer, which is when. When is easy because we actually have probably the strongest evidence for nutrition in ICU that there is. And my excitement about the evidence is probably more understandable if you consider the context of that, which is that nutrition is difficult to study. Nutrition is hundreds of different compounds and they all react with each other and they balance against each other. So you can't just do a study where you change one specific thing about the nutrition. Say I want to give someone more protein, now they're getting more energy. If I want the two groups to get the same energy, then the other group has to have more fat or carbohydrate. So now I've changed more things. And if you have more fat, you've probably got more fat soluble vitamins. If you've got more carbohydrate, you've got more glucose, maybe you've got more fiber, some different vitamins there as well. You can't just change one thing. And I mean, you guys would know critically ill patients are hard to study also because they're the most heterogeneous group we have in the hospital. And it's a moving target. If you look at what we've already seen about the metabolic response to critical illness, the outcome measures that we use in nutrition studies are affected by the critical illness process. So we can't just measure people the way we normally do. Nutrition outcomes tend to have a wide range of individual variability as well. So then we end up with studies that require a lot more participants to get decent power for our study, and that makes it expensive. It makes it time consuming so that you can go 6 years and not reach your recruitment target. And we've also got the complex interrelationship between critical illness and nutrition, where you can see that the way that we handle fuels is different in critical illness. We've got a catabolic state, which we don't normally have in health. We've got fuels cycling around in the bloodstream that aren't normally there in large amounts. Extra glucose is in the bloodstream, extra lipids are in the bloodstream, extra amino acids are in the bloodstream. And because of insulin resistance, the way we're utilizing and releasing those fuels is different from normal. So if nutrition is difficult to study and critically ill patients are difficult to study, then critical illness nutrition is really difficult to study. And that means that when you have a bunch of studies that all get a significant result for critical illness nutrition, and the outcome measure is the money shot one, it's mortality, you can see now why I feel like it's kind of a miracle that we have this evidence. And that's the evidence for early enteral nutrition, that is within 24 hours of ICU admission, is associated with a lower mortality rate. It's a miracle. And it's study after study finds this. Now, why is it enteral nutrition and not just nutrition? Mainly not because of the nutritional properties, but because of the gut's role in the inflammatory and the immune responses of the body. It's also maintaining gut function, maintaining the motility and secretions that keep the gut working, because a failing gut is a source of other organ failures. So it's really important. Feeding into the gut maintains gut function. It maintains the gut's ability to keep a barrier against pathogens and letting them get further into the body. And of course, the inflammatory and immune role of the gut is something that feeding into the gut early actually maintains, so actually ameliorating the effects of a hyperinflammatory state that affects all sorts of other body processes. And yes, also because nutrition is good, but particularly feeding into the gut gives you benefits that intravenous nutrition doesn't give. So better glycemic control, you have incretins in the gut. I kind of think of the gut as being totally just covered in taste buds like the tongue is. It's like one big tongue tube. But you've got also incretins in the gut, which augment the effect of insulin. And during insulin resistance, the incretins aren't as affected. So you've got better glycemic control, which is important on a full body scale, and also better control of protein utilization. instead of just nutrients coming through a central line and cycling around the body where any cell that's greedy can grab nutrients for itself, you've got them all going to the liver where there's better coordination and better control of which amino acids can be converted to other amino acids and what we need. So you can see here the diagram just showing the whole body effects. If you start up near this guy's head, on either side of his head, you've got a box pointing to the heart and to the lung, reflecting the fact that if you can reduce excessive inflammation, you're actually preventing organ dysfunctions elsewhere in the body. And then if we go clockwise, we've got some other things about the inflammatory response and the role of the gut in the immune function. And then continuing clockwise, we come to actual nutritional things about maintaining muscle and having better muscle function and better rehabilitation prospects. And all of these are from specifically feeding into the gut. Now, when we say early, some of the guidelines say 24 to 48 hours, but if you actually look more closely at the evidence they're basing those recommendations on, the real significant effects are within 24 hours of ICU admission. And it's really because all of these things to do with the inflammatory and immune responses are happening really fast. One of the senior researchers in, I think, was it one of the earliest studies on glutamine and the effects of glutamine in critical illness? He said, really, if you get hit by a bus, I want you to miss at most one meal. We need you to be fed by the time your next meal would have been due. If you get hit by a bus on the way to work, you can miss lunch, but I don't want you missing dinner. We need to have started nutrition by then, because that's how fast all the inflammatory stuff happens. We need to jump in before that gets out of control. Also, gut motility and secretions are affected by the fight or flight response, which again is in seconds from the insult. And those secretions, because they act as signals to promote normal motility, and these things are also happening really quickly. We do want to get the nutrition into the gut early. And again, metabolic reasons, remembering that our glycogen store, which, you know, you might have been taught at uni that your glycogen store starts to run out after a few days of starvation. That's talking about the glycogen in your liver plus the glycogen in your muscles. And yes, together those two give you enough glycogen to keep your blood glucose at a reasonable level for the first couple of days of starvation. But remember, if you're not using the muscle, you don't have access to the glycogen in the muscle. And the amount in the liver is really just there for your overnight fast. So you start to become catabolic once that starts to run out. And if you have insulin resistance at the same time, then that's also promoting catabolism and promoting inflammatory and immune responses. So starting some nutrition before all that has time to really take hold makes a big difference to the overall inflammatory response in the body. Just noting that catabolism starts early, you can see nitrogen balance really just dropping within that first day. So if we can start to reduce that nitrogen balance by making up for some of those losses as early as possible, then that should make a difference. You've seen these slides earlier today, but just to remind you that catabolism isn't just something that affects the early part of the ICU stay. It has lasting effects. It has outcome effects. I think Leanne showed this study showing that 5 years after someone was in ICU, they still have functional disability. And this one where we can see that skeletal muscle predicts ventilator-free days, ICU-free days, and mortality. Andrew showed you this slide, just really emphasizing that it wasn't to do with how much they weighed. It was actually their sarcopenia and the muscle quality, and both of which deteriorate really rapidly early in the stay if we're not providing the protein that they need. And you also have seen how there's a bit of a difference between the guidelines recommendations. With energy provision, their advice on when to start and how to start is actually conflicting. The American guidelines recommending reaching 80% or more of the patient's goal within the first 72 hours in ICU admission, and the European guidelines recommending not aiming for more than 70% of the patient's requirements within the first 48 hours, and really going for that above 80% level only after day 3. If you look at what the evidence was that they cite in these guidelines, you'll see that some of them are looking at different studies, which I guess is appropriate if they're trying to reflect what local practice should be, because certainly practice in ICUs differs between America and Europe, and here we are in the middle and we're able to pick and choose, but we really need to look at that evidence to see which of the studies really apply to our patient populations and our practice. And this one, which Andrew showed you before from Darren Halen's International Nutrition Study, starts us off by realizing that as the amount of energy decreased, mortality increased. And the trend was for all groups, but it's notable that the significant effects were really in the obese and the underweight patients. We've also looked at this one before. So this is the Eden study, and you can see that although they didn't find a significant difference between trophic and full enteral feeding in these early days, the difference really, there isn't a difference in the outcomes, and this Zeman study really maybe explains that underfeeding and overfeeding are both associated with increased mortality compared to hitting that apparent sweet spot of 60 to 70% of the patient's measured requirement. So it's kind of this U-shaped curve, and I think a lot of studies maybe have got two groups which both have increased mortality because they might have compared 100% to something much lower than that 60 to 70 that seems to be ideal early in the stay. Emma showed you this graph, and really I just kind of bring that together with our message about early feeding, that the endogenous fuel supply starts high in the first few days and decreases. And if we get too excited about starting full goal feeds right from the start, even though that looks like we're actually meeting the person's needs, we may actually be overshooting if you take into account the amount of endogenous fuel that's cycling around in the body. So it's really important to remember that that's there. But what we actually give probably does kind of meet up with an appropriate amount if you consider that the Darren Halen group found people are getting about 60 to 70% of the goal. People are mostly getting the lower amount that is recommended. And so starting early, remembering that most of the benefits of starting early weren't nutritional ones. They weren't about providing a huge amount of fuel. They were about keeping something going through the gut, maintaining normal motility and secretions. That doesn't require you to reach the goal. That just requires you to put something in and have it go through the gut and monitor tolerance really closely. So this study also just shows that even the group that said they were aiming to start at the goal rate were still only reaching the goal around day 3, 4, 5. So in that first few days, even groups that say that they're doing an aggressive early nutrition protocol aren't overfeeding. And as Marianne pointed out earlier, feeding enterally, there aren't really any studies showing that anyone successfully overfeeds anybody using enteral nutrition alone in the first few days in ICU. For protein, Leanne's taken you through a whole bunch of the evidence, and it does seem a little bit simpler. The evidence is a little bit less mixed. If you look at that Zeman U-shaped curve again for energy, in the original paper, it's side by side with what may be a really huge U that extends way, way up into the many grams per kilo of protein. But the little bit that we see in the amounts that we're able to give with the products we have, there isn't a U. It just keeps, mortality goes down as you give more protein. So it does give us a bit more of a positive signal. The guidelines are not that conflicting about protein requirements in the ICU, but as Leanne pointed out, the main problem that we have with protein is how to get enough protein, because we always have to take into account how much propofol someone's having, and most places when someone's on a high rate of propofol, the first thing that they do, if that's a sustained high rate infusion, is to reduce how much other nutrition that we give, and that's necessarily reducing how much protein and micronutrients the patient's getting. Unfortunately, propofol doesn't come with protein and micronutrients. It would make our lives so much easier if it did. Fluid restrictions. When we look at products later in the workshop, we'll be talking about the effect of fluid restrictions on the nutrition we can give. The limited range of formula and the amount of protein that they have in them, and the problem with giving modular protein, whether it's utilized in the same way that protein is when it comes as a mixed nutrition, and how much extra fluid we have to give when we give modulars is another thing that becomes a barrier to providing extra protein. With PN, the story is a bit different about early feeding. It's much easier to overfeed. There's a higher risk of all sorts of complications. There's an increase in incidence of infection. There's an increased risk of fluid overload. So when we're using PN, we really need to be a bit thinking a bit differently, because it is so much easier to overfeed early. When becomes controversial, the guidelines again conflict a little bit. The old ESPEN guidelines used to say if early EN wasn't possible, then early PN would meet the nutritional requirements, but everyone has now pulled back from that message. The US guidelines have always been a little bit more cautious about early PN, but most of the studies showing poor outcomes that they were relying on were managing lipid quite differently, and I don't feel like they apply to our practice. But the evidence doesn't support being too cautious and just not being ready to add supplemental PN if a patient really is not meeting their needs and days go by. So we've actually already talked about the Tikakos study, and I think the points that raises have been made. Other studies where parenteral nutrition is provided in a large amount early on seem to be associated with disadvantage, but if you look closely at some of those studies, you'll find that if they included malnourished patients, the malnourished patients are the only ones who show any benefit or tend not to have that disadvantage. So again, it's really important to look individually at your patients and identify what difference it makes. In the calorie study, there wasn't actually a difference in infections between enteral and parenteral when given early. So that's really important. There's benefits and risks, obviously, to both enteral nutrition and parenteral, but I think early on, it's really important to see that what benefits we're looking for with early nutrition primarily are from the benefit of keeping the gut working and the effect that that has on outcome. So parenteral nutrition can wait a little bit. This meta-analysis showed significantly fewer infectious complications and a shorter ICU length of stay without an obvious change in the recommendations. So enteral nutrition should be considered first-line nutritional therapy if their gut is working, and we can maintain that working. So to summarize when and how, it's really important to start within 24 hours to see if we can get that mortality benefit for our patients. But I think the takeaway message about all that endogenous fuel is there's no pressure to meet the full requirements if the patient isn't tolerating. Individually, patients who do tolerate a higher rate of enteral nutrition early on probably aren't those patients that are at risk of, you know, they may be the ones that actually are not severely ill, the patients who are post-op surgical patients, they're not unstable metabolically, they're actually probably not having a huge acute phase response, and they're able to utilize that nutrition. Don't wait for signs of gut function The evidence is probably stronger on this than anything else, and it's probably the most ignored bit of evidence we find working with other clinicians who come down to ICU and say, oh, you know, we're worshipping the voodoo god of flatus, show us a sign, voodoo god, we can't feed until the voodoo god has shown us a sign. This is really what it sounds like, superstition. The gut function will actually be promoted by feeding a little bit of feed in, and it's not going to put the patient at increased harm. We want to use enteral nutrition wherever possible, even if we're only providing a low rate along with parenteral nutrition, just to get those gut function benefits and the immune benefits from using the gut. If the patient is malnourished or at high risk, then they probably don't have the same risk of disadvantage from early PN, but definitely avoid for overfeeding. Watch out for all those extra calories like dextrose, propofol, nimodipine, clofidipine. Yeah, they do create lots of difficulties meeting protein and micronutrient requirements because we're having to take them into account. Avoid interrupting and stopping feeds, and be conservative with estimating requirements. If you can measure it, that's even better.